Imagine losing a limb. It's a reality for around 2 million people in the US right now.
Yeah, and the numbers keep growing. Over 185,000 new amputations each year just in the States. Globally, it's significant too.
It really is. It's a part of healthcare that, well, many of us probably don't think much about unless it affects someone we know directly.
And it's usually not just a single event, is it? It's often the culmination, the endpoint of long-term health problems.
Right, a whole complex medical journey. Difficult decisions and then, the recovery, the adaptation afterward.
That whole path.
Exactly. So for this deep dive, we're using a really detailed chapter from a medical text to kind of pull back the curtain.
It's packed with information from lots of different studies, clinical perspectives.
Our goal here is to really break down this dense info for you.
Yeah, we want you to get a quick grasp on the key things. Who's most at risk, why it happens, and importantly, how often it might be preventable.
And also what the medical side looks like, the process, and then what life is like afterward.
Let's get into it.
Okay, so first things first, defining amputation.
Right. Simply put, it's removing a limb or part of a limb. The text makes a distinction, between primary amputation, the initial one, and secondary ones, which might happen later, sometimes after attempts to, say, restore blood flow didn't work out.
Okay. And when we look at where these amputations happen, the vast majority, like 80%, are lower limbs, legs and feet.
That's right. Lower extremity amputations, or LEAs, are the big focus.
And even within those LEAs.
About 2/3 are below the knee, maybe a third are above the knee. Arms and hands, upper extremity amputations, they're much less common, maybe 15–20% of the total.
So this source material is really concentrated on issues affecting the legs.
Definitely. And, well, to understand why, you really have to look at the strong link between LEAs and chronic diseases.
Yeah, this is where the numbers, they get pretty stark, don't they? The source is really clear. Amputation is deeply tied to underlying health issues.
Oh, absolutely. Somewhere between 30 and 60% of LEAs occur in people who have diabetes mellitus.
Wow, up to 60%.
And a huge number, 80% of Americans needing NEA, have peripheral artery disease.
PAD, that's the arteries narrowing, right? Usually in the legs, restricting blood flow, like clogged pipes.
Exactly like that. And the text describes how it can progress. Sometimes no symptoms at all, asymptomatic.
Right.
Then maybe claudication, that's pain or cramping when you walk. Later it can become rest pain, hurting even when you're not moving. And finally, tissue necrosis, tissue death.
But the text says people can skip stages.
Yeah, that's the surprising thing. A lot of people apparently go straight from having no symptoms to really severe pain or, actual tissue death. It doesn't always follow that neat progression.
That makes sense why sometimes it seems to escalate so fast, and the source flags specific risk factors as major warning signs.
Huge warning signs, one of the biggest. Absent sensation on the bottom of the foot, often from diabetic neuropathy, nerve damage.
Just not being able to feel things.
Right. And the source says this simple loss of feeling leads to a 10 times higher risk of getting a foot ulcer.
10 times.
And wait for it, a 17 times higher risk of amputation.
17. Just from numb feet. That's shocking. I wouldn't have guessed that. It totally changes how you think about nerve damage.
It really underscores how vital sensation is for just, protecting yourself from injury without realizing it.
Makes sense.
And if someone with diabetes does get foot ulcers that keep coming back, their risk of amputation jumps to between 5 and 15%.
Okay. And smoking.
Another major one. It doubles the risk of critical limb ischemia, that's severe blockage threatening the limb itself.
Well, you've got diabetes, PAD, nerve damage, smoking. It sounds like they all pile on top of each other.
They absolutely amplify each other. Having both PAD and diabetes together, that dramatically ups the risk of wounds not healing, worsening neuropathy, and gangrene, which, directly drives up the need for amputation.
And the text mentions certain groups are affected more than others.
Sadly, yes. Men are twice as likely to have an LEA as women, and the source points directly to significant racial disparities in the U.S. African Americans face 2 to 3 times the risk for diabetes-related LEA compared to white individuals. The text suggests this might be linked to, well, inequalities in healthcare access.
Okay, reporting what the source says there, those numbers highlight potential systemic issues beyond just individual health.
And Native Americans have an even higher rate, 3.5 times that, of non-Hispanic whites.
Wow.
And what's really sobering, too, is for patients who've already had one LEA due to vascular problems, The risk doesn't stop there.
Oh, no.
They have a 20 to 50% chance of needing the other leg amputated within just 1 to 3 years.
That really points to the underlying disease being systemic, affecting the whole body, doesn't it?
Exactly. It's usually not just one leg. And the mortality rates associated with this, they're significant.
How significant?
The source cites a 39 to 68% mortality rate within 5 years after a vascular-related amputation.
Almost a coin flip to 2/3 chance within 5 years. That's
Yeah.
incredibly high.
It is. And if you factor in other serious health problems, comorbidities like end-stage kidney disease, ESRD, which often goes along with diabetes and circulation issues,
The odds get worse.
much worse. Survival rates drop drastically. For those with both diabetes and ESRD needing an amputation, it's about 50% survival at 1 year and only 15% at 5 years.
15% survival at 5 years. Those numbers are just stark.
It really drives home that amputation in these cases isn't just about the surgery. It's often a sign of very advanced, life-threatening disease.
Precisely. So we've talked about who is at risk. Maybe we should dig a bit more into the why, the specific sequence of events, the triggers that lead to that point.
Okay, so what does the source list as the main culprits, the primary why?
Well, to reiterate, the big three are peripheral artery disease, diabetic foot ulceration, and peripheral neuropathy. Those are the most common drivers.
But not the only ones.
No, not at all. The text mentions a whole range of other contributing factors, things like physical trauma, obviously.
But also infection, just generally impaired wound healing, limited joint mobility, which can create pressure points. Malignancy, like cancer in the limb, severe thermal injuries, burns, or frostbite congenital malformations people are born with, and even really bad skin fungal infections.
And what about other health conditions beyond diabetes and PAD?
Yeah, the source notes conditions that can cause neuropathy.
Yeah.
Things like thyroid disease, spinal stenosis, amyloidosis, alcoholism, vasculitis.
Okay.
And then there are conditions that decrease peripheral perfusion, meaning less blood flow to the limbs, congestive heart failure, Berger disease, scleroderma.
And medications can sometimes contribute too?
Yes, that's mentioned. Some drugs, like certain chemotherapies or antiretrovirals used for HIV, can cause neuropathy as a side effect. And others, like some beta blockers or alpha agonists used for blood pressure, can potentially decrease arterial flow, although that's more complex.
This all leads to a really crucial question the source addresses.
Yeah.
When is amputation actually indicated? When does it become the necessary step?
It's generally when other options, particularly limb salvage attempts, aren't possible or haven't worked.
Like trying to restore blood flow first.
Exactly.
Yeah.
So if someone has severe or chronic ischemia, that lack of blood flow, and it hasn't responded to revascularization efforts,
Okay.
or if there's irreversible tissue damage, massive muscle death, or just intractable pain that can't be managed any other way, sometimes amputation becomes necessary to save the person's life, stop infection from spreading, or even improve function when the limb just can't be fixed.
Given all those contributing factors, especially the links to chronic diseases that can be managed, it really makes you think about prevention.
And that's a huge emphasis in the text, primary prevention.
So can we actually prevent this in many cases?
Absolutely. The text is really optimistic here. The most effective approach is tackling those major risk factors we talked about head on.
Like managing the diabetes, the high blood pressure?
Exactly. Controlling diabetes, hypertension, coronary artery disease, definitely quitting tobacco, managing kidney disease and high cholesterol, and be really proactive about existing foot issues like ulcers or calluses.
So it comes down to those foundational health habits again.
Pretty much. Lifestyle changes are huge. Dietary adjustments for blood pressure, blood sugar, cholesterol. Stopping smoking, the earlier the better. And regular exercise. These are all key to slowing down or stopping the underlying diseases.
And foot health seems particularly vital, especially with diabetes.
Oh, incredibly so. The source highlights that comprehensive foot care programs for people with diabetes are amazingly effective.
How effective?
Programs that include regular wrist checks, patient education, preventative measures, and getting treatment quickly when needed. They can cut amputation rates by 45 to 85%.
45 to 85%. That's a massive impact just from focused foot care.
It really is. It shows that catching small problems early can make a world of difference.
So these programs are crucial.
And the text also notes that up to 90% of diabetic foot ulcers can actually heal.
90%. How?
With the right approach. Appropriate antibiotics for infection, restoring blood flow if it's poor revascularization, and aggressive wound care. That includes offloading the ulcer.
Offloading. Meaning taking pressure off it.
Exactly. Using special shoes, casts, or just resting it so the tissue isn't constantly being stressed and can actually heal.
So the text really pushes back against the idea that small foot problems automatically lead to amputation.
Definitely. Proactive, proper care is incredibly powerful.
Okay. But let's say prevention hasn't worked, or maybe it's a trauma case. What does the assessment process look like when amputation is being considered? How do doctors figure things out?
It's a really thorough evaluation. It combines what the patient tells in their history, their symptoms, with what the medical team observes during a physical exam.
So what the patient reports, subjective stuff.
Right. Things like numbness, burning sensations, pain, especially pain that gets worse at night or when lying down, that's a key sign. Also, any foot odor, swelling, history of past foot problems or ulcers, claudication when walking, smoking history is huge, and even details about the shoes they wear.
Things the patient themselves would notice or feel.
Exactly. Then you have the objective findings, what the clinicians see and measure during the exam.
Like checking sensation.
Yep, using a monofilament. It sounds fancy, but it's just a thin plastic thread they touch to different spots on your foot to map out any loss of sensation.
Simple but effective.
Very. They also test reflexes, look very closely for any foot deformities or calluses, and examine the patient's footwear.
Footwear keeps coming up.
Because it's such a common preventable source of pressure problems, especially if there's neuropathy. They check the fit, look for wear patterns that show where the pressure points are.
Makes sense. What else?
They assess blood flow, checking pulses in the feet and legs, looking at capillary refill time.
How quickly the color comes back after pressing the skin.
Exactly. They inspect the skin carefully for subtle signs, hair loss, dryness, discoloration. They look for deformities like hammer toes or claw toes, or signs of Charcot arthropathy.
Charcot arthropathy.
That's a really severe joint breakdown, often linked to diabetic neuropathy that can cause major foot deformities. They also check how well the joints move, look for limitations.
They really are examining every detail.
Every inch, meticulously checking between the toes for ulcers, moisture, redness, palpating, gently feeling the legs and feet to check skin temperature, feel for pulses again, check for swelling, or any signs of infection, necrosis, or gangrene.
And the text mentioned age in this context, too.
Yeah, just noting that while trauma can happen at any age, these non-traumatic LEAs, the ones linked to chronic disease, tend to start showing up around the 6th decade, so in your 60s, and then increase dramatically in the 8th decade, the 80s.
Okay. What about diagnostic tools? Tests they use to get a clearer picture.
Right, they use a bunch of tests. Not just to see if the limb can be saved, but also if amputation is needed to figure out the best level for the surgery.
To ensure good healing and potential prosthesis use later?
Exactly. You want the best possible outcome.
So what kind of tests are we talking about?
There are non-invasive ones, things that don't break the skin, like segmental blood pressures, using Doppler ultrasound to listen to blood flow, skin perfusion pressure tests, temperature checks, measuring oxygen and CO2 levels in the tissue itself.
So checking circulation right at the skin level.
Precisely. Also nerve conduction tests and vibration tests for neuropathy, standard x-rays, and pulse volume recordings to assess blood flow changes.
And more invasive tests.
Those might involve injecting something, dye or isotope measurements, bone scans or leukocyte scans to look for infection, and crucially, angiography.
Angiography.
That's where they inject dye into the arteries and take x-rays to see the blood vessels clearly. It's really key for seeing blockages and figuring out if revascularization, like a bypass, is even possible.
The roadmap of the arteries.
Basically, yeah. CT and MRI scans are also used for detailed images of tissue and bone.
And just standard blood work.
Oh, yeah. Basic labs are always part of it. Complete blood count, metabolic panel, checking inflammatory markers like SED rate and C-reactive protein. Gives an overall picture of health, nutrition, infection signs.
So it's a really comprehensive workup before any big decisions are made.
Absolutely. Amputation is a major step, and that decision is always based on a very thorough understanding of the whole picture.
Okay, let's shift to the decisions right before and during the surgery itself. For someone with severe foot issues, is amputation always the first surgical thought?
No, definitely not for non-traumatic problems. The source is clear. If it's feasible, revascularization, restoring blood flow is a preferred first choice, especially for ischemia lower down in the limb.
Trying to save the limb first.
Right. Procedures like bypass surgery, even down to tiny arteries in the foot, can absolutely be limb-saving.
But it's not always possible.
Correct. The text mentions a significant chunk, maybe 14 to 20%, of people with critical limb ischemia just aren't candidates for that kind of reconstruction.
Yeah.
Maybe the blockages are too extensive downstream.
So amputation becomes the primary option then.
Or sometimes, even if revascularization is technically possible, it might not be the best choice for that specific person.
How so?
Well, for someone who is already, say, wheelchair-bound or has severe neurological problems or a very limited life expectancy, putting them through a major revascularization surgery might not actually improve their function or quality of life much. In those cases, amputation might be considered the more appropriate path.
Okay, that makes sense. So if amputation is the plan, what needs to happen right before the surgery? What are the priorities?
Medical management beforehand is crucial. Top priorities. Stopping smoking, like as early as possible, ideally weeks before, and continuing until healing is done.
Huge emphasis on quitting smoking again.
Always. Also, getting blood sugar under tight control, often using insulin, managing blood pressure, and treating any active infection is absolutely vital.
How do they treat the infection effectively?
The source stresses getting good tissue cultures after the wound is cleaned to pinpoint the exact bacteria. But usually start antibiotics right away, broad-spectrum ones, based on the likely culprits, while waiting for those culture results.
And the text really hammered home the connection between pain before the amputation and phantom pain after.
Yeah, that's a really interesting point it makes. Controlling pre-op pain isn't just about comfort. There's actual evidence suggesting that prolonged, severe pain before surgery increases the risk and intensity of phantom limb pain later on.
Like the nervous system gets stuck in a pain loop, this pain memory idea.
Exactly. That's the concept mentioned. The nerves kind of learn the pain. The text even touches on the idea of using really intensive pain relief before the surgery, maybe for 72 hours, with drugs like calcitonin or ketamine, to try and break that cycle, potentially interrupt that pain memory.
Wow, so addressing pre-op pain might actually prevent a major post-op problem. That's powerful.
It really is. It shows how complex pain is. Then comes the big surgical decision, selecting the level of amputation.
Where exactly to make the cut?
Right. This takes real clinical judgment, plus all those test results we talked about. The goal is always the lowest possible point on the limb that meets two criteria.
Yeah.
It has to heal reliably after surgery.
Oh, okay.
And D, it has to allow for good fitting and function with a prosthesis later, if that's the goal.
And the level chosen makes a big difference functionally.
Huge difference.
Yeah.
Generally, the higher up the limb the amputation, the more proximal, the more functional impairment you'll see.
And energy costs.
That too, significantly. Walking with a below-knee prosthesis takes roughly 10 to 40% more energy than normal walking. But an above-knee prosthesis, that takes 50 to 70% more energy.
Wow, that's a big jump.
It is. And just using crutches, with no prosthesis at all, can demand about 60% more energy.
So preserving knee function, preserving length, it's really critical for mobility if someone hopes to walk with a prosthesis.
Absolutely. When it comes to the actual surgery, the techniques, the source lays out some key principles. Choose the site in healthy tissue with good blood supply. Remove all the dead or non-viable tissue. Use antibiotics. Handle tissues gently. Control bleeding meticulously. Shape the remaining limb, the stump, correctly for a smooth surface. And crucially, avoid tension on the sutures when closing.
Makes sense. And there are different ways to approach the surgery itself.
Yes. There's what's called an open or guillotine amputation. That's usually for severe trauma or bad infections.
They leave it open.
Yeah, the wound is left open initially, allows drainage, lets them keep an eye on it, but it'd be the second surgery later to actually close it up.
Okay. And the more common way?
That's the closed amputation. The incision is made in healthy tissue, skin flaps are carefully designed and shaped, and it's closed immediately, right at the end of the first surgery.
What about this auto amputation?
Ah, yeah. Non-surgical or auto amputation. That's really only for very small, clearly defined areas like maybe a single toe that's become gangrenous but isn't infected secondarily.
The body just separates it.
Essentially, yeah. If there's no spreading infection, the body can naturally wall off and eventually separate the dead tissue over time, like nature doing the work on a tiny scale.
Interesting.
For specific procedures, the text gives examples. Like for an above-knee amputation, they often use a fish mouth incision shape. They're very careful about handling nerves and blood vessels to prevent problems like neuromas later. And the bone is cut precisely and smoothed.
And below knee?
A common technique uses a long flap of skin and muscle from the back of the calf. And getting the bone lengths right is really important for fitting a prosthesis well later. For a below knee, they often aim for the tibia, the main shin bone, to be about 11 to 15 centimeters long below the bottom of the kneecap.
Very specific measurements.
Yes, for optimal prosthetic function.
And if the problem is just in the foot, not needing a full below knee?
Right, there are more limited options for distal problems. A Symes amputation goes through the ankle joint but cleverly preserves the heel pad.
The heel pad. Why?
Because it's naturally designed for weight bearing, so it can provide a really durable end to the stump for walking, sometimes even without a prosthesis for short distances. Then there are transmetatarsal amputations, removing the front part of the foot, or just toe or ray amputations, taking one or more toes and maybe the associated foot bone.
So it's really tailored to exactly where the problem is and what the goals are.
Highly tailored. And, well, like any major surgery, the text is clear that there are potential complications.
Ah, yes, the potential bumps in the road after surgery. What kind of risks are we talking about?
Well, there are general risks that can affect the whole body. Things like, sadly, death, though rare, blood clots, DVTs, chest infections like pneumonia, heart problems, angina, heart attack, stroke, and then issues specific to the stump itself, like accidental trauma or excessive swelling.
And problems that tend to show up fairly soon after the operation.
Early on, you might see issues like excessive pain, infection developing in the surgical wound, problems with wound healing, or joints getting stuck in a bent position. Those are called flexion contractures.
Contractures, right.
Or problems with how the muscles were stabilized over the bone end. If they're not secure, it can lead to the bone feeling prominent or the stump feeling kind of flabby, which makes fitting a prosthesis difficult.
Okay. And what about challenges that crop up later on?
Later complications often tie into wearing the prosthesis. Things like the stump swelling up inside the socket, which is called stump congestion, or the stump developing a bulbous shape that doesn't fit well.
Skin issues.
Definitely. Calluses, cysts forming on the skin. Neuromas, those painful nerve endings at the cut site, can become problematic. Bone spurs or even bone overgrowth can happen. And sometimes the scar itself adheres tightly to the bone underneath, causing pressure points and skin breakdown inside the socket.
So getting the surgery done is just the first step. There's a lot to manage afterwards to avoid these issues.
Absolutely. Which leads us right into the whole process of management and rehabilitation. It's way more than just the operation.
The text really stresses the care both before and after.
Yes. Preoperative nursing care, for instance, is described as absolutely vital. It's about getting the patient physically ready, good hydration, nutrition, preventing infections or clots, keeping the other limbs strong and mobile.
The unaffected limbs, too.
Critically important. But just as crucial is the mental preparation, helping the patient really understand why the surgery is needed, talking through pain control options, explaining what rehab will look like, and exploring their own personal goals for recovery. What do they want to achieve?
And pain control pops up again here in the pre-op phase.
Yes, the source mentions it again as essential. Controlling that pre-amputation pain is key for comfort, rest, and, as we discussed, potentially reducing phantom pain later. Even simple things are mentioned, like using a bed cradle to keep blankets off a sensitive limb.
That consistent focus on managing pain early.
It really stands out. Then, after surgery, comes rehabilitation. The source emphasizes this is an active process, and it needs a dedicated team.
Who's on that team?
It's genuinely interdisciplinary. You need the surgeon, a physiatrist.
A physiatrist.
Yeah, that's a doctor who specializes in physical medicine and rehabilitation. Then physical therapists, nurses, and importantly, amputee volunteers.
People who've been through it.
Exactly. Their lived experience is invaluable. Plus, a prosthetist, the expert who designs and fits the artificial limb. A nutritionist, a social worker, and absolutely central to it all, the patient and their family or support network.
It really does take a village, so to speak, and rehab starts before the surgery.
That's a key takeaway from the source. Preoperative rehab is a real thing. It focuses on keeping the unaffected limb mobile and strong, preventing contractures there, general physical conditioning, and also doing a psychosocial assessment.
Understanding the patient's emotional state and support system beforehand.
Exactly. Preparing them physically and mentally for the road ahead. Then, post-op rehab continues that journey, moving from the acute hospital setting to outpatient therapy, maybe home-based therapy, as healing progresses.
The text brought up some specific challenges for older patients regarding using a prosthesis.
It did. It notes that getting someone successfully fitted and walking with the prosthesis can be particularly tough in the geriatric population, especially for folks over 85.
What makes it harder?
Several factors are listed. How mobile the person was before the amputation is a huge predictor, being over 70 generally. Having other significant health problems, kidney disease, heart failure, dementia, fixed joint contractures that can't be straightened out, severe arthritis. These can make walking after amputation unlikely, or are even considered reasons not to pursue prosthetic rehab.
So the success of getting someone walking again with a prosthesis really depends heavily on their overall health and condition before they even have the surgery.
It absolutely does. It's not automatic, and it hinges on many factors beyond just the surgery going well.
Which logically leads us to thinking about life after rehab, living with limb loss long term. What kind of guidance does this source offer on patient teaching and home care?
Education is framed as absolutely key, empowering the patient for long-term success.
And does that prevention message carry through even after an amputation?
Oh, definitely. Ongoing lifestyle changes, quitting smoking for good, controlling cholesterol and blood sugar remain critical, especially for protecting the remaining limb from developing the same problems.
Makes sense. What about practical tips for managing at home?
The source suggests giving patients things like pictures of exercises, clear instructions for skincare, even menu ideas focusing on high protein and carbs to support healing and energy.
And knowing when to call for help.
Crucial. Patients need clear instructions on red flags. Any skin changes on the stump cracks, blisters, sores, rashes, increased redness, any increase in stump pain or the stump feeling warmer than usual, or any unusual odor, those all need a prompt call to the doctor or clinic.
And checking out the home environment itself.
Yes, very important for safety, preventing falls, especially when someone is first learning to get around with crutches, a walker, or a new prosthesis. That means looking for tripping hazards like throw rugs, making sure there's good lighting, dealing with slippery floors, and arranging things so frequently used items are easy to reach without stretching or bending awkwardly.
Reducing fall risk is paramount.
Absolutely. The text also advises just allowing plenty of time for activities, not rushing, while adapting to new ways of moving.
It sounds like a really significant adjustment period needing ongoing care and support.
It is. And the source acknowledges the psychological side, too. The sense of loss of control, maybe impacts on self-esteem, potential changes to income, social life, hobbies. It makes the point that while one wound, the surgical one, might be gone, ongoing diligence is needed for skincare, pain management, and overall well-being.
Are support resources mentioned?
Yes, thankfully. Things like the National Amputation Foundation are highlighted, offering practical tips for new amputees and their families. And local support groups are mentioned as being really valuable.
Connecting with others who get it.
Exactly. That shared experience provides reassurance and practical advice on managing everything from stump care to navigating daily life.
It's really clear that good outcomes depend on so much more than just the surgery, comprehensive care, education, and that strong support system are all vital.
They are absolutely essential pieces for helping someone move forward, regain independence, and maintain a good quality of life.
Okay, so we've really covered a lot of ground here. The scope, the numbers, who's at risk, the underlying causes, prevention strategies, the detailed assessment and diagnostic process, the surgical decisions and techniques, potential complications, and that whole critical path of rehabilitation and long-term management.
Yeah, we have. Amputation is clearly a major medical event, often, as we've seen, resulting from complex chronic health issues. But the takeaway is that with understanding, with proactive prevention when possible, skilled medical and surgical care, and really comprehensive rehab and ongoing support, successful adaptation is definitely achievable.
Thinking back to those statistics we started with, especially the disparities, the source highlighted the racial disparities, the high risk of needing a second amputation for vascular patients. Reflecting on all this information, what does it really tell us about the critical importance of, well, equitable and accessible preventative care, particularly for those populations the source identified as being at the highest risk?